All right, future nurses, get ready, because today we're going deep on respiratory assessments. You know, that crucial skill you'll be using nonstop throughout your nursing career.
And we're here to help you move past just memorizing the steps. We're going to unpack the why behind every single technique so you can connect those assessment findings to what's truly going on inside your patient's lungs.
Love it. So, picture this.
Yeah.
You're in clinicals, and you have a patient with breathing difficulties. Where do you even start?
Well, even before you touch the patient, it all begins with a super thorough patient history. Think of it like detective work you're gathering clues.
Okay, so we're playing detective. What kind of questions are we asking to uncover those clues?
You want to kick things off with the presenting problem. What brought the patient in? Is it a stubborn cough, shortness of breath, chest pain that's got them worried?
So we're homing in on their specific symptoms.
Right, and we're going to dig deeper. How long has this been going on? Constant. Or does it come and go? What makes it better? What makes it worse?
This is where those detailed questions come in.
Absolutely, because even those seemingly random symptoms like fatigue, weight loss, even night sweats, they can actually be tied to respiratory issues. You'd be amazed how often those seemingly unrelated pieces complete the puzzle.
It's like connecting the dots between all these different symptoms.
Exactly. And understanding the presenting problem means figuring out how it impacts their daily life. Can they climb stairs without gasping for air? Sleep through the night? This helps you gauge the severity and how much it's affecting their life.
Right, it's about seeing the whole person.
Now, once you've got a handle on their current situation, we go back in time. Past medical history is key here. Have they ever been diagnosed with asthma, COPD, pneumonia, any lung surgeries, hospitalizations for breathing problems?
So we're looking for any past respiratory issues that could be playing a role right now.
Exactly. Every detail from their past helps us understand their present. And of course, don't forget medications. Are they on bronchodilators, steroids? This tells you about their current treatment and whether it's working.
It's all about painting that complete picture.
And a big part of that picture is social history, which can feel kind of awkward to ask about, but it's super important. Think about smoking that includes vaping and secondhand smoke. Huge impact on respiratory health.
And their work environment too, right?
You got it. Occupational hazards, big time. Do they work around dust? Chemicals, asbestos, even hobbies like woodworking can be an issue. And don't shy away from recreational drug use. Some drugs can really mess with lung health, so it's crucial to know.
So we're gathering info on all aspects of their life, habits, environment, everything.
And lastly, never underestimate the power of genetics. Family history is a gold mine. Do they have a family history of asthma, allergies, cystic fibrosis? These things can run in families, so it helps you identify potential risks.
Okay, so we've got their symptoms, their past, their lifestyle, their family history. It's like we've put together a puzzle, right?
Exactly. And now the real detective work begins. We take all these pieces and start forming a hypothesis about what might be causing their breathing difficulties.
So that initial conversation is much more than just paperwork.
It's the foundation for your physical assessment. It helps you make sense of everything you'll find.
Which brings us to the hands-on part, which I know can feel a little intimidating for new nursing students.
I get it. But don't worry. We're going to break down the physical assessment into 4 key techniques: inspection, palpation, percussion, and auscultation.
Big words, but really it's just looking, feeling, tapping, and listening.
Exactly. We'll walk you through each one step by step, so you'll be confident using them in clinicals.
Okay, let's start with inspection. What are we looking for when we first walk into the patient's room?
Well, the observation starts the moment you walk in. Look at them. Any obvious distress? Are they struggling to breathe? Using their neck and shoulder muscles to help them. That's a sign they're working hard to breathe, and we call that accessory muscle use.
And skin color is a big one too, right?
Huge. Skin color can be a major clue. A bluish tint to their lips or fingertips, what we call cyanosis, that can mean low oxygen levels. It needs immediate attention because their body isn't getting enough oxygen. And it's not just cyanosis itself, but where it is, how widespread it is, that gives you a sense of how serious it is.
Wow, so even subtle changes in skin color can tell us a lot.
Now, you want to pay attention to their breathing pattern. Note the rate. How fast are they breathing? Is the rhythm regular or irregular? And the depth, are they taking deep breaths, shallow breaths? Is it labored? Each variation can point towards different things.
So we're really paying attention to how they're breathing, not just whether they are.
Exactly. For example, you might see Cheyne-Stokes breathing. Breaths gradually increase and decrease in depth, with periods of apnea or no breathing at all. often linked to serious conditions like heart failure or brain injury.
And then there's Kussmaul breathing, right?
Right. Deep, rapid breaths, often seen in patients with metabolic acidosis, like diabetic ketoacidosis. Their body's trying to compensate for high acid levels in the blood.
It's amazing how much we can learn just from watching them breathe.
Now, while you're observing their breathing, don't forget the chest itself. Check the shape symmetrical. Are both sides rising evenly with each breath?
Asymmetry could signal a problem.
Absolutely. Uneven chest movement could mean a collapsed lung or fluid buildup. And notice if they have what we call a barrel chest, where the chest looks rounded and expanded, common in COPD, happens because air gets trapped in the lungs over time.
So during inspection, we're looking at their overall appearance, their breathing pattern, and their chest movement.
You got it. All this before you even touch the patient. Now we're on to palpation, where we use our hands to gather more information.
Speaking of touch, palpation gives us even more insights, like checking for chest expansion.
Right. You'll put your hands on their back, thumbs near the spine, and ask them to take a deep breath. Do both sides move equally? If one side lags, it could signal a collapsed lung or fluid buildup.
So we're feeling for symmetry. What else are we checking for?
This might sound strange, but pay attention to tactile fremitus, the vibrations you feel when they speak. Ask them to say 99 while you place your hands on their chest and back. Increased vibrations could mean fluid or consolidation in the lungs, like with pneumonia.
So those vibrations tell us about the density of the lung tissue.
Exactly. And as you palpate, be on the lookout for tenderness or any unusual lumps or bumps. Could be signs of something more serious, and we need to investigate further.
It's like we're chest detectives. Okay, we've looked, we've felt, now it's time to tap things percussion.
It is. Percussion. It's like that doctor game we all played as kids, right?
Yeah.
But now it's for real. We tap on the chest wall to hear what's going on inside.
But how does tapping tell us about their lungs?
It's all about the sounds. A resonant sound, which is kind of hollow, means healthy, air-filled lungs. Dull thud might indicate fluid or even a mass.
What about a really booming sound?
That booming sound is called hyperresonance, and it can mean air trapping, like in emphysema. Lungs lose their elasticity and overinflate, creating that hyperresonant sound.
Who knew tapping could reveal so much? Okay, last but not least, we have auscultation time for the stethoscope.
Yes. Here's where we really tune into what those lungs are telling us. You'll listen for different breath sounds. And it's super important to distinguish between normal and abnormal sounds.
So, starting with the normal sounds, what should we hear in healthy lungs?
The most common one is called a vesicular breath sound. It's soft, rustling, low-pitched. Some people say it sounds like wind in the trees. You'll hear it over most of the lung fields.
Sounds peaceful. Now, what about those abnormal sounds? What red flags should we be listening for?
These are the ones that make you go, something's up. One you'll hear a lot is crackles, also called rails. Imagine a subtle popping or crackling sound as they inhale. That's a crackle. Often means there's fluid in the lungs. You might hear it with pneumonia or heart failure.
That doesn't sound good. What else should we be aware of?
Wheezes. Imagine a high-pitched whistling sound. Often means narrowed airways, a classic sign of asthma.
Wheezes and crackles. Got it. Anything else?
Yes. Raunchy. Low-pitched snoring sounds. Usually means mucus in the larger airways, and you often hear them with bronchitis.
Crackles, wheezes, raunchy. Anything else that raises an eyebrow?
One more, and it can sound kind of scary, pleural rub. It's a grating sound, like sandpaper rubbing together. Means there's inflammation between the lung and the chest wall, like with pleurisy.
Okay, we've covered a lot of ground patient history, those 4 main parts of a physical assessment, and some key things to look, feel, and listen for.
We've given you the tools to gather those clues, but the next question is, how do we know what it all means? That's what we'll dive into next.
We'll be right back to talk about interpreting your findings and recognizing those common respiratory conditions. And we're back. All right, so we've gathered all those clues from the patient history and the physical exam. Now it's time to put on those detective hats and figure out what it all means.
Time to connect the dots. We're going to show you how specific assessment findings can help you pinpoint exactly what's going on. You'll start to see patterns, Certain combos of findings often point to specific respiratory conditions.
So let's play detective. Let's say we have a patient coming in with a cough, fever, and chest pain. During your assessment, you find increased tactile fremitus, dullness on percussion, and crackles when you listen to their lungs.
Ah, yes, that classic trio, a strong indication of pneumonia. Remember, increased tactile fremitus, that means the lung tissue is denser, probably due to fluid or consolidation. Dullness on percussion that backs it up tells us something other than air is filling those alveoli and those crackles. That's the sound of fluid popping open as they inhale.
So we're not just listening for the sound, but also thinking about what it means anatomically.
Absolutely.
Okay, let's switch gears to another common one, asthma. What kind of findings would you expect to see there? Think about what's happening in the airways during an asthma attack.
Well, the airways are constricted, so I'm guessing we'd hear wheezing. Bingo. With asthma, you'll probably find normal fremitus because there's no consolidation. Percussion might be normal, or even hyperresonant if there's air trapping. But the giveaway, often those wheezes, you hear that high-pitched whistling from those narrowed airways.
Okay, makes sense. Now, how does COPD, chronic obstructive pulmonary disease, how does that look different from asthma?
COPD can be tricky. It often involves a mix of emphysema and chronic bronchitis. Now, in emphysema, the walls of the alveoli are damaged, which causes air trapping, and those lungs get overinflated. This leads to decreased fremitus and hyperresonance on percussion.
So both asthma and COPD can cause wheezing and hyperresonance, but COPD also has decreased fremitus. What else should we be listening for in a patient with COPD?
You might also hear raunchy, those low-pitched snoring sounds because of mucus in those larger airways, especially if chronic bronchitis is part of the picture. And pay attention to their breathing pattern. You might notice a prolonged expiration as they struggle to get air out.
So it's all about looking at the whole picture, not just individual findings.
100%. Now, let's do one more. Pleural effusion. What clues would tip us off there? Imagine fluid building up between the lung and the chest wall.
That fluid would muffle the breath sounds, right?
Yeah,
So I'm thinking decreased breath sounds.
you got it. With pleural effusion, you'll likely find decreased fremitus, dullness on percussion, and diminished, maybe even absent breath sounds, all because that fluid is in the way.
Wow, so many conditions, so many findings. It can feel a little overwhelming, especially when you're just starting out. Any advice for our nursing students who are trying to learn all of this?
The best advice: practice, practice, practice. The more you do these assessments, the more comfortable you'll become. You'll start to recognize the sounds, connect the dots between those findings and the conditions. Think about the scenarios we just talked about. Try to visualize what's happening in those lungs and how that translates to what you hear, feel, and see.
I love that. Connect the sounds to the anatomy. And don't be afraid to ask questions. Your clinical instructors are there to help.
They are. They've been there, and they want you to succeed. And another thing, remember that a respiratory assessment isn't a one-and-done thing. You'll be reassessing your patients regularly, monitoring their progress, seeing how they're responding to treatment. So those initial findings, they're just a starting point.
It's about using those findings to guide your care
Yeah.
and make sure your patients are getting the right treatment.
Exactly. And that's what makes nursing such a rewarding challenge.
All right, future nurses. So far, we've covered how to do a comprehensive respiratory assessment, how to interpret your findings, and how to recognize some of those common respiratory conditions. Feeling empowered yet?
I hope so. We've covered a lot in this deep dive. But remember, it's just the beginning. There's always more to learn. Keep exploring, keep asking questions, keep practicing.
And with hard work and passion, you'll be those incredible, compassionate nurses you're meant to be. Now, one last thing before we move on. We've talked about how smoking, occupational hazards, and family history can all impact respiratory health.
Right, but what about other lifestyle factors? Those can affect breathing too, right?
Exactly. Things like exercise, diet, stress, even where you live. Think about how those might play a role in lung health. We'll leave you with that question as we head into the final part of our deep dive. All right, nursing students, we're in the home stretch of our respiratory assessment deep dive. In this final part, we're going to focus on really honing those observation skills, becoming those nurses with, laser focus who can spot those subtle respiratory clues that others might miss.
Yeah, observation is such a huge part of nursing. And it's especially true with respiratory assessments. It's not just about going through the motions of, inspection, palpation, all those things, but about really seeing your patient and noticing those little signs that might be saying, hey, something's changing.
So we're taking it a step beyond the basic techniques, really fine-tuning those observation skills.
Exactly. And sometimes those subtle signs, they're the first clue that something's wrong, even before the patient themselves realizes it. You might see a change in their, their demeanor, skin color, breathing pattern, something that just makes you go, that's not quite right.
Okay, let's break it down. What are some specific things we should be looking for? Where do we even begin?
Let's start with their general appearance. How are they positioned? Are they sitting upright, leaning forward, lying flat? Their posture can give you a lot of information about their breathing effort. Like, someone with COPD might lean forward, bracing themselves with their arms to help them use those accessory muscles to breathe.
So even just how they're sitting can be a clue.
Oh, absolutely. Now look at their face. Are they grimacing, pursing their lips as they breathe? Those can be signs of increased work of breathing. Or anxiety. And speaking of anxiety, watch for signs of restlessness or agitation. Those can also point to respiratory distress.
Interesting. So we've got posture, facial expressions. What about their skin? We already talked about cyanosis, but are there other skin changes that we should be looking for?
Definitely. Look for pallor paleness or diaphoresis, which is sweating. Those can signal poor oxygenation or just increased effort of breathing as the body tries to compensate.
Okay, posture, facial expressions, skin. How about their chest? We already inspected it during our assessment, but are there other things to be aware of?
Even if you've done your hands-on inspection, keep observing that chest, throughout your time with them. Look for any asymmetry in the movement. Is one side lagging behind? That could be a pneumothorax, where air leaks into the space around the lung, or a pleural effusion, where fluid builds up.
And then we talked about retractions too, right? Where the skin between their ribs or at the base of the neck sinks in when they breathe in.
Exactly. Retractions, they tell you the patient's really struggling to breathe, using those accessory muscles to try to get enough air. Another thing to watch for is paradoxical breathing, where the abdomen moves inward during inspiration instead of outward. Could mean a problem with the diaphragm.
So we're watching for asymmetry, retractions, paradoxical breathing. How about their hands and feet? Anything to look for there?
Check their fingers and toes for clubbing. It's a rounding and thickening of the nail bed. Sign of chronic hypoxia, low oxygen levels in the blood, often seen in lung diseases like cystic fibrosis.
Wow, it's amazing how much you can learn just by observing your patient. It really highlights how crucial it is to be a good observer, constantly looking, assessing, putting the pieces together.
It really is. And remember, your assessments don't stop once you've finished the initial exam. You're always observing your patients, right? Looking for changes that might mean their condition is getting better or worse. Those little cues can be super valuable.
It's about that ongoing assessment, connecting what you see with what you know about respiratory conditions and what you found in your assessment.
Exactly. And when you put all these pieces together, you're well on your way to providing truly excellent, compassionate care.
All right, nursing students, that wraps up our respiratory assessment deep dive. We covered everything from gathering that super important patient history to those hands-on techniques. And finally, we gave you those observation skills to become true respiratory detectives.
And remember, this deep dive was just the start. There's always more to learn. We encourage you keep exploring, keep asking those questions, keep practicing those skills.
And with dedication and a passion for learning, you'll all be those amazing, compassionate nurses you were meant to be. Thanks for tuning in.